everybody who doesn't know, this is Scott Kostolni. He's the chief operations.
Oh, that's who you are.
I know.
Okay, so in pre-hospital medicine, there are a lot of sacred cows. These are skills, treatments, and concepts so ingrained in the psyche of EMS that speaking out against them labels you as a heretic. We're often taught them early, we accept them as gospel, and we spare them never a second thought. Today, I'm going to show you guys a couple of these sacred cows, shine some light on them, and expose them for what they truly are. Utter trash. So, let's make some sacred hamburgers. Nothing is more ingrained in the minds of EMS providers than lights and sirens. Many people become first responders just so they can drive the big trucks, sound the wee-woos, and run the flash attacks. They save time, save lives, and keep us safe, right? Well, in May of 2017, the Department of Transportation and the National Highway Traffic and Safety Administration released a 98-page document condemning the routine use of lights and sirens in medical transport. It turns out that lights and sirens do save time, but often it is less than 1 minute, and this time saved makes absolutely no difference in patient outcomes. Instead, they found that accidents that happen during medical transports almost always happen when lights and sirens are being used. Not only are these accidents preventable, but they come with a very high incidence of morbidity and mortality. Even if you don't get in an accident, you and your patient are still more likely to become injured, suffer permanent ill effects such as hearing loss, or fall victim to medical errors just because lights and sirens are on. With all of this risk and no benefit to show for it, why do we still do these things? Is the excitement and bravado really worth it? Is it worth this? Morphine, oxygen, nitroglycerin, and aspirin have long stood as the standard pre-hospital treatments for cardiac chest pain. But these treatments aren't really all they're cracked up to be. Let's take a look at morphine first. We use it to relieve discomfort, drop sympathetic tone, and decrease the workload of the heart. All of this sounds great, but when actually put to the test, morphine shows some concerning side effects. Antiplatelet agents, such as aspirin, are frequently used to slow the buildup of clots, but morphine actually works against them and decreases the effectiveness of these medications. The Crusade study done in 2005 found that ACS patients given morphine are twice as likely to die as those who are not given it. An MRI imaging study done in 2015 revealed larger infarctions and less salvageable cardiac muscle in patients who received morphine than those who did not. Uncontrolled chest pain is not okay, and we need to manage it, but morphine is probably not the best choice here. Now, during a heart attack, the blood supply to the heart is blocked and it starves it of the oxygen that it needs. Giving more oxygen in hopes that a little bit extra will make it to the cardiac muscle makes sense, right? Wrong. Listen, anyone who spent more than a few minutes with me knows about my absolute fucking hatred for the empirical use of oxygen. Oxygen is a drug. When used correctly, it can save a life. But when used incorrectly, it can debilitate and kill. A 2016 Cochrane review of 5 separate trials found that there is absolutely zero evidence to support the routine use of oxygen in chest pain and heart attacks. Alternatively, the AVOID trial showed increased troponin, CK, and mortality in patients that were given just 8 liters per minute of oxygen versus patients given none at all. Patients given oxygen have larger infarction sizes and a higher likelihood of subsequent MIs and cardiac arrhythmias. If your patient is hypoxic, by all means, get their sats up. But if they were already satting above 95%, you're not going to help them by slapping on that non-breather. Instead, you may actually end up choking off that last bit of blood flow that's still keeping them alive. Gone are the days of nitroglycerin opening up the coronary arteries. The drug actually does do this, but the plaque buildup inside the occluded vessel actually prevents it from working in that spot. Instead, now we give nitro to lower the blood pressure and to help control pain, and it's really good at doing that. But there is a little risk here. See, when you drop the diastolic blood pressure, you also drop the coronary perfusion pressure. This is the pressure that brings the blood back to the heart muscle and actually feeds it. If you give too much and lower that pressure to too low, you're going to end up choking off any of the blood that is actually getting there. And finally, aspirin. Aspirin, like I said, is an antiplatelet medication which prevents an occlusion from getting worse. There is nothing negative to say here. Aspirin is fantastic and has been shown time and time again to be safe and effective in decreasing mortality in patients having an MI. It is also an effective preventative measure and reduces subsequent heart attacks. Follow the advice from this guy and give this shit to your patients. So if Mona is out, what are we going to do instead? Well, there's no really good answer. I kind of came up with APOC, so aspirin always, pain control, but make sure you watch their blood pressure, oxygen only when necessary, and transport that patient to a cardiac center. All right, so back in 1979, the average survival rate for patients in cardiac arrest was between 8 and 10%. In response, the American Heart Association released guidelines to help improve care. Thanks to ACLS, in 2018, the average survival rate for cardiac arrest is still between 8 and 10%. So why has there been no improvement in the last almost 40 years? Turns out ACLS really isn't the golden ticket we wanted it to be. Let's start by looking at CPR and defibrillation. Do these things actually work? Yes, for the love of God, do this on your patients. There is something called the NNT, or the number needed to treat. This is how many times you have to perform a treatment before it actually helps one person. The NNT for CPR is only 17. For defibrillation, it is 2.5. These are fantastic numbers and make it super clear that this is where we need to be spending our attention during cardiac arrests. But what about epinephrine? Well, as it turns out, there's actually never been any evidence to support the effectiveness of epinephrine in cardiac arrest. A 2014 review looked at 10 different studies on the use of epi, with the conclusion epinephrine is not associated with improved outcomes and may actually lead to worse ones. Now, these are observational retrospective studies, so they don't prove causation. What you need for that is a randomized controlled trial. Thankfully, this year, we got one. Paramedic 2 was a large, double-blind, randomized trial which concluded that epinephrine made no significant difference in patient survival. And patients who were treated with epi and did survive were twice as likely to have severe neurological deficits, never being able to walk again, care for themselves, or go to the bathroom without someone else's help. The number needed to treat here to save one life in epinephrine is 112. Okay, so what about dextrose? Dextrose actually isn't part of the ACLS guidelines anymore. It was added in 2005 and then removed, and it hasn't come back. But I still see a lot of ALS providers giving this medication. We actually have never had any evidence that low blood sugar causes cardiac arrest. There were some case studies that were presented, but all of these case studies are not very good, and their patients had extreme severe comorbidities, such as coronary artery disease, brain bleeds, and acute pancreatitis. In truth, none of that really matters because we can't even test for hypoglycemia in cardiac arrest patients. The glucometers we use are only 38% effective, much less than flipping a coin when the patient's heart isn't beating. But what about giving it just in case, empirically? Well, I don't really like giving empirical medication. See, a review of over 4,000 arrests looked at the effects of dextrose in cardiac arrests and suggests that it may actually exacerbate brain damage. Additionally, a randomized controlled trial performed in cats, mirrored this, showing that cats that were given sugar before cardiac arrest was induced had much worse brains than the ones that did not after they were revived. Dextrose definitely needs some more research, but until some kind of benefit is shown, I have more important things to do with my time. Bicarb is another favorite of older ALS providers. There is no evidence for bicarb that bicarb helps our patient. It does reduce acidosis, which is great, but that reduction in acidosis does not translate to improved patient outcomes. Alternatively, retrospective analysis shows decreased survival for patients given bicarb. And it's not that bicarb is harming anyone, it's just that when we finally decide to give it, it's been like 40 minutes and any effect it might have is completely useless. It's just an exercise in futility. So looking at the whole picture, what's the NNT for ACLS care and cardiac arrest? There isn't one. Or more appropriately, it's approaching infinity. ACLS doesn't help cardiac arrest care patients. Are the guidelines going to change in 2020? Well, probably not. I mean, if you take out all those medications that I just talked about, what's really left in ACLS care except just CPR and defibrillation, which is what you should be focusing on. All right, here's my last one, and it surprised the crap out of me when I learned it. There's a medication frequently given in our ambulance without a second thought that has the possibility of harming even our healthiest patients. Anyone want to take a guess at what it is? Oxygen. No, that is a good answer, and it is actually accurate, but that's not what I want to talk about today.
So Frank.
I want to talk about normal saline. But let's strip down that name because there is absolutely nothing normal about saline. Let's take a look at the normal components of our blood. We have 140 milliequivalents of sodium, 105 of chloride, and a pH of around 7.4. This is healthy for us. Saline, on the other hand, has 10% more sodium, 50% more chloride, and is way more acidic than what is actually normal. This takes a toll on our patients. Infusions of saline cause electrolyte imbalances, acidosis, renal damage, and the potential for increased mortality. This year, 2 studies were published, and these effects are shown both on critically ill and non-critically ill patients. You're drunk that you dump a liter of saline in can get kidney damage from it. Now, I know that we really don't have another option when it comes to fluid. There are better options out there, but until they become available to us, we're kind of just going to have to give saline and try to remember what it's going to do to our patients. This is what this whole talk boils down to for me. I don't expect you guys to go against your protocols or change your practice, even though I think you probably should. But I am begging you to take a look at the data that's out there. You will find some very surprising things. The most important thing I learned in med school was not the ACLS algorithm or how to eat taquitos at 80 miles an hour in the city. It was how to look at data and critically think about what my treatments are doing for my patients. And I urge you guys to do the same. If you disagree with anything I presented up here, I challenge you to find the evidence and prove me wrong. I would be delighted if you can. So thank you guys. I usually have references. Unfortunately, I didn't get a chance to type them up, but references and more information will be available at that address tomorrow, whenever I finish typing them up at work today. Thank you guys.
Questions?
Yeah, of course.
So I can, for the oxygen, you said to look at the set, and I know like a bunch of people here like keep telling me treat your patients rather than the number. So like with oxygen, if they're having chest pain and we're supposed to give them oxygen, how am I supposed to know like besides the number that if they need oxygen or not? Like, you know what I mean? Like, because their chest pain, they already have shortness of breath, they already are like in kind of anxiety and all that. How can I separate that from like being it from chest pain or being because of they're being hypoxic?
So it's going to be hard to, and that's where the SAT is kind of important, but the saturation can be wrong. ALS providers have end-tidal CO2, which is a different device that can kind of help us with that. But basically, it's going to come down to what Jaffa was saying. Do an assessment on the respiratory system after you finish treating their chest pain. If they're not belly breathing, if they're not using their intercostal muscles or working hard to breathe forward in a tripod position, then the issue they're having is probably not pulmonary in origin. Also, everyone's going to tell you to keep using oxygen. It's fine.
Anybody else? Okay, so for your APOC acronym, so instead of using morphine, fentanyl?
Yeah, fentanyl's great. You're going to come down between using fentanyl or nitro. Okay, nitro's great. I love using nitro, but I got to take a look at the blood pressure. Right. If the diastolic blood pressure starts getting to around that 80 milligrams, millimeters of mercury, I'm going to try to switch to fentanyl. It's also going to depend on how much pain they're in. If it's tons of pain, if they're at 10 to 10 and they're screaming, fentanyl is going to be a better option straight up. Nitro's not really going to reduce it that much. But if just a little bit of pain, nitro popping in their mouth is super easy.
So when it comes to like doing some of these protocols, particularly ACLS, when we get to like the H's and T's part of cardiac arrest, they're usually in asystole, and these are the patients that are basically Hail Mary. So we're basically throwing the kitchen sink at them, and that's when it comes into the bicarb, the dextrose, and things like that. And it's basically at that point that they're going to have a very low likelihood of survival anyway. But there are like situations where using bicarb would be helpful, such as like a TCA overdose or a patient who's on dialysis, who can certainly reverse that. So while there hasn't been proven instances of it working, there are some areas where you still want to give these medications anyway. And of course, follow your protocols.
One of my favorite discussion points on ACLS is designed for podiatrists that need to run a cardiac arrest. It's designed for doctors who are not good at resuscitation to have a basis of understanding, a guideline, thank you, for what they should be doing. we run these arrests all the time. We should be getting more educated, and we should start moving beyond just what the ACLS guidelines says. Yeah, tricyclic antidepressant overdoses, dialysis patients, they need calcium, they need bicarb, those things will work on them. But just blatantly giving it because the guideline told us to is kind of what I'm trying to get us away from.
Like throw the kitchen sink at them, sure, but like be smart about it.
So just out of curiosity, what's a safe alternative to saline? Like you were saying.
There's something called lactated ringers, which is just a different, it's water with a couple different chemicals. It's closer to our blood pH and the chemicals that are in it. Unfortunately, doesn't work well with all of our medications. There's some medications that you absolutely cannot give with lactated ringers. The two solutions that are being used in other places, just not the US yet, is Isolite and Pedialyte. These are almost identical to the blood stream. Sorry, not Pedialyte. Pedialyte's good too.
I was like, what?
No, Isolite and another light. It's not Pedialyte.
Evolite.
Damn, I can't think of what it is. But those are the options, and they will hopefully be coming out in the US somewhat soon.
And then the other option is like D5W maybe.
Yeah, D5W is not bad.
Certain scenarios.
Depends what you're giving.
Because that's the thing, like D5W can just like run through a patient and not do anything. And it also can dehydrate them even further because of that.
What was surprising for the research on saline was that it only took a liter to a liter and a half of fluid to start seeing these effects on healthy patients. I've given myself more than that last time I was sick. And the idea of just tossing that in there because we don't think anything about it, but I actually am having an effect on my physiology is super important for us. We need to critically think that every single thing we use, saline, oxygen, Zofran, have different effects on our patients and our patients' bodies. We need to know what those are as providers.
Here we go.
Go ahead.
Oh, me?
Yeah.
So, just going back to the first one, the lights and sirens, the study that you were looking at, was it that for responding to the patient or like overall like?
So both, for the most part. What they found was that about 5% of patients saw some benefit from the use of lights and sirens. And we know these patients. These are our patients in cardiac arrest or our trauma patients that need surgery. These are patients that are actively having a heart attack in front of us. Yeah, we're not going to stop at every red light and drive super slow. But those dangers that exist are still out there for us. What we should be doing is we should be driving slower. When we are going to use lights and sirens, we should be stopping at lights and going through an intersection after we've made sure everyone's stopped for us. Going 90 miles an hour down city streets or Levittown streets is not beneficial. The less than 2 minutes or the less than 1 minute average was a national average. In areas like ours, for normal transports, we will see an average of 37 seconds saved for the use of lights and sirens. That's it.
And if you ever go through the driver training program here, we actually do teach you to like stop at every single intersection and check and make eye contact with each provider or each driver because it really, when it comes to the time scale that we're talking about here, you're more likely to get into an accident if you don't like the sirens or blues and twos that they call it in England than they are anywhere else. Secondly, if you want to see some like amazing driving and some like amazing training, look up the Met Police. That's the London Police. They do some fantastic driver training, and they basically have to verbalize what they're doing and what they're thinking about the entire time through. And they'll actually like come to an intersection and they'll stop, they'll turn off their lights, and they'll wait for the light to turn green, and then they'll proceed through it. Their lights and sirens back on again, because it doesn't make that much of a difference. And you're more likely to get yourself hurt and never get to the assignment in the first place. Any questions for anyone?
Oh.
Ready come up? So, I'd like to thank you all for being here. I'd like to thank you all for watching at home. This is Scott Kostolni, Diana Mono, and Jennifer Ahmed. Thank you very much.